Good afternoon, everyone, or as I learned to say in my first teaching job at A&M, howdy. I'm also a proud Houstonian, so I need to report to you all that I have travel papers from the mayor of Houston that require me to be back in our city by midnight or I'm subject to dire penalty, there being no rivalry between our two great cities. And of course, both of us live in the second best city in the state. We all know the first best city is Fort Worth. When you got the Kimball Art Museum, right, and the Fort Worth MoMA, I love the art museums in Houston, but sorry, they just don't match up. Okay, so I'm going to talk about ethics with y'all, and so we're going to talk about responsibly managing emerging ethical challenges in newborn screening, and we're going to do two things. First, I'm going to give you a conceptual vocabulary in which to think about these ethical issues. Then we're going to work through some of the very issues that Dr. Powell set up for us, and we're going to think about them together. What you will discover as we go through that list is it gets harder and harder to think through these issues. And so the area of bioethics basically divides up into two groups. There's stuff we can figure out pretty easily. The challenge then becomes how do we get it done? And then there's stuff that's just really hard to figure out. And we'll see we're going to start with the stuff that may be straightforward and then get pretty quickly to the stuff that's hard. So we're going to give you a nomenclature, especially the concept of what's an ethical obligation. We'll define the components of an ethical framework, and then we'll put those together to answer the question, how should we respond to the increased scope of next generation sequencing in the context of newborn screening if we go that way? The principal barrier to it, I think, is twofold. One is cost, and the second of all is the delay in getting the information for conditions where you need to know very early in childhood what to do with it. But if the turnaround time can be sped up, I wouldn't be surprised, but I wouldn't also be surprised that the cost of that will go up as well, because there's opportunity cost. Those people are pulled off other things, and that cost has to be covered as well. So first, just to get cleared up on language, genetic testing and screening is language that can be a little fuzzy. So as a philosopher, the first thing I try to do is get language as precise as we can get it. So genetic testing seeks a diagnosis of a condition, disability, disease, disorder, or syndrome. You're after all of those in an individual patient. But genetic screening, as I hear it being used, is vague among three meanings. First, it seeks for risk assessment. That is, what is the increased or decreased risk of a particular person for a particular condition, disease, or whatever, against a general background population of some kind. Next, it seeks diagnoses of conditions in an entire population of patients, or it does both diagnosis and risk assessment in an entire population of patients. And failure to be clear about that is bound to create confusion. So I suggest that we think about that genetic screening we should think about as risk assessment. That is, we're trying to figure out what is the increase or decrease risk of disease in a particular patient, which means that we need to replace genetic screening with genetic risk assessment and then population-based genetic testing. So newborn screening, as I understand it, is population-based genetic testing. But next generation sequencing is going to add risk assessment to the capabilities. Is everybody with me? So it's already getting hard, and we're only on like slide 3.